I'm going to leave right now, and I'm going to introduce Branch Coslett, who is the Director of Cognitive Neurology here at University of Pennsylvania. He's a terrific colleague and expert in behavioral neurology, and Branch is going to talk with you about corticobasal degeneration. Here's the pointer, very straightforward, and this is great. Okay.
Thanks very much, Murray. I was about to give him the hook. I don't know about you guys. He had about another 30, 60 seconds to go. So I'm going to be talking today about this condition, corticobasal degeneration. It goes by many names, as I'll mention. So my talk is going to be aimed primarily at people who don't have a huge sophistication about the background of these diseases, the neuropathology, et cetera. So I'm going to talk more about the clinical presentation, the symptoms that are associated with this disorder. I'll leave some time for questions and would welcome questions if they're burning questions as we go. I misspeak, as you'll hear, so frequently that sometimes I get a lot of looks that people say, what is he saying? That happens a lot to me. I've come to recognize it. So if I misspeak so badly that you don't understand, please just let me know, and I'll try and clarify whatever it is that I butchered the first time. Okay, so corticobasal ganglionic degeneration, first described by this guy, Rebbe, in 1968. So, this is a pretty long time after Alzheimer's disease was described in 1906, 1907, probably reflecting a point that I'll come back to. It's relatively uncommon. It was called different things. It turns out that these kinds of patients were probably seen and reported in the medical literature as far back as the 30s and called so-called parietal pics and various other kinds of things. But the real condition that we're talking about now for this next 25 minutes or so, corticobasal ganglionic degeneration, was first described in the form we know today not that long ago as these conditions go. Pick's disease goes back, to 1890 or something. So this is relatively recent. It also goes by these terms: corticobasal ganglionic degeneration, corticobasal degeneration, the term we're using, and actually I'm just going to call it CBD because it's easier. Yeah, there we go, CBD. And it is not Alzheimer's disease or frontotemporal lobar degeneration, Pick's disease, dementia with Lewy bodies. It's really a distinct disease, at least at the level of the brain. As we will discuss, it's a distinct disease that can be hard to differentiate from some of these other conditions. But at least when you get Dr. Trojanowski and Dr. Lee and these world-class people who look at the brain under the microscope and start figuring out the underlying problems, it's a distinct disease, it seems. Okay, so I said it's relatively uncommon. So this is what I mean. So if you take 100 people who come into a clinic for evaluation of symptoms consistent with dementia, probably, the numbers differ from one site to another. It's something in the order of 2/3 of them, maybe a little bit more, will have Alzheimer's disease. Another 15% or so will have dementia related to small strokes. And then you get into this dementia with Lewy bodies, which you'll hear about next from Dr. Sidoroff, and frontotemporal lobar degeneration, about which you've heard from Dr. Grossman. Then you're left with CBD. Now, I don't take it as a slight that they asked me to talk about the one that nobody ever sees, but it's only about 1% of patients with dementia in these clinics. It's really rather uncommon, but well recognized, and often we think relatively distinctive disorder. It seems to affect men and women about equally. There's a couple studies that suggest women get it a bit more frequently, but that's not generally thought to be true, I believe. And like so many of these conditions, you could fill in the blank for the condition. Family history in about 15% of cases. So this seems to be the ballpark for many, many of these degenerative conditions of the brain. There are patients with family histories, no question about it. That is family history in the sense that it runs from one generation to the next. That's what I mean by family history. Or there's 2 sisters or 4 siblings with it. That kind of thing is what I'm talking about for family history. You'll be hearing more about genetics from Beth Woods in a bit, and she knows far more. If I'm butchering anything, I defer to Beth. But family history, in my sense, is that it runs in families as more than one person in the family across generations or in the same generation. About 15% of the time that occurs in CBD. So it's not real high. What that means also is if you have a loved one with the condition, the odds that you or your children will get it is relatively low, it seems. Now, nobody can give you exact numbers. That's one of the difficult things about these conditions, but it's not something that just runs in family like Huntington's disease, where you've got a major risk for offspring. Okay, so the differential diagnosis, just a couple things with which it's often confused. And I'll come back to this. Progressive supranuclear palsy, and again, talk about rare disorders. This is something that's even rarer than CBD probably, and it's very much in this ballpark. I'm not going to mention it too much, but this is an overlap. Some people even believe this is the same disease. It's often confused with Parkinson's type symptoms, not usually Parkinson's disease, but Parkinsonian symptoms of the dementia with Lewy bodies type, and multisystem atrophy, which is another one of these Parkinsonian symptoms. What I mean by Parkinsonian symptoms is there are features of Parkinson's disease, but it's not true Parkinson's disease. So it overlaps in a lot of ways, but it is not classic Parkinson's disease. One of the crucial things that differentiates these Parkinsonian symptoms from Parkinson's disease is, points for the right answer, tremor. So Parkinson's disease, as you know, typically has this resting tremor. These kinds of conditions tend not to. So that's the sense in which it's like this disease, but not exactly the same. Okay, so how does it start? Well, it's a curious thing. We used to think that corticobasal ganglionic degeneration started most of the time with motor system problems. And I'll describe these in some detail because they're very striking and they're very unusual. It turns out, with Dr. Grossman and a number of his colleagues having led the way in some of this area, that it turns out that a lot of the patients with corticobasal ganglionic degeneration, or CBD, I don't know why you said all that, CBD, a lot of these patients will show up with problems with thinking and memory in ways that I'll come back to first, rather than show up with the problems with the movements. So it can be either way. That is, people often start with CBD by going to a movement disorder specialist who specializes, say, in Parkinson's disease, and other people end up coming to see Dr. Grossman or Chatterjee or me, somebody who specializes more in the thinking kinds of disorders. So it can show up either way. Dr. Grossman has been very interested in the problem with language, and this probably is the presenting complaint in about 50% of people who turn out to have CBD, as judged by autopsy. This is an important point, as judged by autopsy, which is the gold standard still. Changes in personality and behavior, which Dr. Grossman had emphasized in FTLD, are much less common in this condition. They occur. This 22% figure came from a big study from the Mayo Clinic where they had 36 autopsy-proven patients. And 22% of those patients had prominent changes in personality and behavior. So it's relatively uncommon compared to many of the other diseases that cause a progressive decline, many of the other degenerative diseases. Okay, so what are these problems with movements that I described? They're really sort of hard to describe in a sense, and they're quite striking. And I'm sure some of you in this room have seen them. And you know what I mean when they say they're hard to describe. Well, sure, people with this condition have problems with walking. They tend to walk in a sort of stiff way, short steps, not turn very well. If you say turn around, do this kind of thing. They tend to have akinesia. That is, people will sit and not do very much. So their eyes won't blink as much. The average person in the room blinks 15 times per minute. People with these kinds of conditions blink, 6, 7 times a minute. They tend not to fidget. If you look around, if you get bored, which I hope you won't in the next 20 minutes, but if you do, look around and see nobody sits still. No, everybody's doing this, they're doing that, they're changing position, they're grooming. Everybody, this is what we do. Nobody sits still, except people with these kinds of conditions, these so-called extrapyramidal disorders. So they have this so-called akinesia. But all of these things are nonspecific. The slowness of movements, which is part of this akinesia, is nonspecific. But one of the things they have that really differentiates this condition from many other conditions is a loss of control of movements. In its most florid example, it's referred to as alien hand, which is a rather striking and sort of, I think, descriptive term. What people with alien hand do is they seem to lose control of one of their extremities. It can be the leg, and it can be the whole arm, not just the hand. But people will act. The hand will do things, and people will say, I didn't want to do that. The hand reaches out and does something, and they say, why did that happen? I didn't mean for that to happen. And this is very characteristic of this disorder. I've seen people, for example, who are eating, and their bad hand will reach into the plate and get in the way of the fork. And they say, that's crazy. I didn't want to do that. somehow this hand just did this. They pull it back, and then the hand wanders off and does things. So this kind of peculiar phenomenon, which is well described in the neurologic literature, and usually in the context of other kinds of problems, is seen in CBD. And it's seen with some regularity. Now, it's often not so the flagrant kind of, I'm combing my hair with this hand's messing it up. I know, this is Dr. Strangelove kind of things. And those conditions do exist, but not usually in this. In this kind of condition, it's the hand sort of, I'm combing my hair, and the hand may be doing this kind of funny posturing or getting in the way. And sometimes the hand will end up back here, and they'll say, oh, man. And then if they think about it, they can control it. It's just that it tends to wander, tends to do peculiar things. Part of this same kind of condition is that people develop what we refer to as an apraxia. By that, I mean they lose the ability to deal with objects. So if you say to them, what's this? And they'll say it's a fork, for example. What's this? It's a cup. And you say, show me how you use it, or use it to eat. They grip it the wrong way. They hold it the wrong way. They sort of misorient the fork, the utensil with respect to the food, and just can't do it right in ways that are really very disruptive, even though you say, squeeze my hand, they're fine. Do you feel this? They're fine. Touch your fingers like that, they're fine. They can do all this sort of elementary motor things, but they have a trouble with the use of objects in a real-world setting. And that trouble, as again, some of you no doubt have seen, can be extraordinarily disabling, getting to the point where some people are utterly unable to, for example, feed themselves because they can't make their hand control the fork and get to the food in ways, and then get to their mouth in ways that they would like, even though the hand works fine if you had asked them to do this kinds of thing. So these kinds of symptoms are really rather distinctive for CBD, we believe. Now, so I mentioned this alien hand. I did want to mention something briefly here. To illustrate this sounds, I know this stuff sounds weird. So just last week, I saw a gentleman in the outpatient unit. And the complaint that was offered by his caregiver was that she was at work. He was going out the front door to get the newspaper. He got his belt loop stuck on the door handle. And he saw it and reached around, tried to get the belt loop off the door handle, but couldn't do it. So 2 hours later, his neighbor sees this, comes over, says, oh, let me help you, and in a nice, kind way, pulls his belt loop off the door. He knew exactly what was going on. This gentleman, it turns out, has very good language. He's very smart. But the spatial relationship between his body and that door handle, he couldn't figure out. It just couldn't see. He's looking at it, just can't figure out how I would move, what I would do to get that belt loop off the door handle. That, to me, is sort of the classic kind of symptom that you see in CBD. Dr. Grossman and I and our colleagues like to ask people in the clinic to do things that some of you may have done, which you think, why are they asking this stupid thing? So we say, can you do this? Can you do this? This kind of thing. People with CBD don't seem to get the relationship between their hands and their body. And if you say, can you do this? They sometimes look at you and say, is that right? And I'm talking people who are very intelligent with normal language who just don't compute the relations of their body and space. It can be a very restrictive kind of problem and pretty disabling. People will try and sit in a chair and miss and sit on the floor. That kind of thing, and learn to, if they're going to have to sit in a chair, to put their hand on the chair so that they know where the chair is, as defined by their hand, not by their body and vision. It can be quite disabling. Oh, the other thing I put in capitals so I wouldn't forget and almost did, asymmetric. So most conditions that we see, many conditions that we see, in the so-called degenerative conditions, that start out both sides of the body more or less affected. In CBD, it's classically and characteristically worse on one side. So I was illustrating this with one hand, sort of doing this kind of wandering stuff. It's typically one hand. And I said something before about the bad hand. Yeah, that's right. It's usually one hand that tends to be bad. It can be either one. I think probably more likely the left than the right, but I don't have any real evidence for that. But it tends to be asymmetric. Okay, So memory, the cognitive problems. Now, again, Dr. Grossman's very expert. He and his collaborators, and I play a very small part in this, have studied this somewhat extensively. But it turns out there's certain things that Dr. Grossman and his collaborators and everybody else agrees. Memory loss is relatively uncommon in this condition. It occurs. It occurs. But memory loss in the sense of forgetting, where you put things, where, who you talked to yesterday, that kind of stuff is relatively uncommon. It occurs as people get worse, but in the beginning, it's rarely the presenting complaint. In contrast to, say, for example, Alzheimer's disease, where it's the usual complaint, or at least very prominent in the very beginning. Many people with this condition will have problems with words and concepts, and it often can be mistaken for primary progressive aphasia, one of the variants of frontotemporal lobar degeneration. Math problems, again, Dr. Grossman has been studying this and emphasized this. Math problems, understanding numbers and numerical concepts is often a real problem, and I mean really profound problem. So people don't seem to get the notion at some point of something like 3. What does 3 mean? They just don't seem to get it. What's 3 plus 2? The number knowledge seems to become very poor in many people. All of these, as in so many of these conditions, the exact profile is hard to define, and there's a lot of variability. But these kinds of problems with thinking, language, words, math, show up as the presenting complaint in about 50% of people with CBD. Okay? Memory problems, in contrast to most other conditions in which the brain is degenerating, memory problems are relatively uncommon and relatively less severe. Okay, so I'm going to just briefly go over this because, as I've already indicated, these personality changes are not usually that prominent. They can occur and they can be prominent, but it's not usually the most prominent thing. In fact, in this study that I cited before, 22% of this 36 patients had this in a retrospective study. So it's not a huge number. Depression, which is a very nonspecific symptom in these kinds of conditions, is relatively common, occurring in 50 to 70%, but this depends in part on how one defines depression. That is what one takes to be evidence of depression, and that tends to be somewhat controversial. This is a point that was emphasized in a recent paper, and I think is a very interesting point. So some of you will have had experience with patients with dementia with Lewy bodies. And Alzheimer's disease, kind of the same thing, where visual hallucinations are common. So dementia with Lewy bodies, or Lewy body disease, again, one of those disorders that has many different names, will often show up with visual hallucinations very early. And they can look somewhat like CBD in the sense that they have slowing of movements, this poor walking that I illustrated. But visual hallucinations are very rarely seen in CBD and are a characteristic of dementia with Lewy bodies. So I think this turns out probably to be, the absence of it turns out to be strongly in favor of CBD, right? I thought I misspelled, CBD. Okay, the course of the disease. Well, regrettably, it is a progressive disease. I mean, it slowly gets worse. These kinds of numbers, these are number of months, by the way, I'm sorry, onset between 45 and 70. 60 is about the average. Again, this is sort of in the same range as this FTLD stuff, and but 10 to 15 years younger than Alzheimer's disease. So it's not a disorder of young people, but it's not a disorder of really old people either. Now, this number here is symptom onset to death, averages 5 to 7 years, but variable. So clinicians get this question all the time for obvious reasons. Who wouldn't want to know? One of the first things you're going to ask is what's likely to happen? And usually, those of us in white coats will give you some kind of mealy-mouthed, not very specific answer, and you say, come on, just answer the question. And the reason we don't is because we basically don't know. We can quote you statistics. We can say that on average, life expectancy from time to diagnosis is 70 months or some such thing, but we really don't know. The variability is huge. So it makes it very hard for any of us lacking crystal balls to really determine what's going to happen in any individual case. What you can say, I think, is that in this condition, CBD, the mean from diagnosis or onset of symptoms, either one, to time of death is somewhat less than it is in Alzheimer's disease, but with a lot of overlap. And it's something on the order of 5 to 7 years. But again, with enormous variabilities. And some people, for reasons that we are looking to Dr. Trojanowski, Lee, and their colleagues to elucidate, the course runs much faster, gets worse far more rapidly than other people who you see back year after year after year, and they're sort of, yeah, a little bit worse, but really not very much. And we don't know why that would be. But the variability is huge. And the cause of death is, it's the cause of death in most of these conditions. People get an infection that you can't treat, or sometimes choose not to treat. Okay. So I mentioned, let's see, this is largely redundant. Okay. So the diagnosis. Well, one of the things that I always tell people, and I suspect Dr. Grossman and the other physicians that you may have seen do as well, is pathology is the gold standard. It's only by looking at the brain under the microscope that we can say with certainty what the condition is. That's true in all of these diseases about which you'll be hearing today. It's particularly true in CBD. It turns out that CBD is, we're probably the worst. We're probably about, we collectively, we're probably right about 50% of the time based on autopsy studies. That is, if you look at patients with a clinical diagnosis of CBD, they could turn out to have FTLD, progressive supranuclear palsy, dementia with Lewy bodies, Jakob-Creutzfeldt, Alzheimer's disease. And if you look at people with Alzheimer's disease or FTLD, some of them will turn out to have CBD. So it's confusing, and it's just getting more confusing. And one of the big initiatives, again, here and in many other places, is to look for so-called biomarkers, tests in the spinal fluid, tests in the blood that allow you to differentiate reliably these different conditions. We simply don't have that now. And at this point, with CBD, we're probably 50%. I suspect it's a little higher, but then again, I haven't been, my judgments haven't withstood the test of autopsy, so I can't say. So, but we're not always that accurate. And this is one of the problems. This I bolded because this is, I think, one of the most fascinating things that we're learning from these diseases about the brain. And this, I'm going to spend just 1 minute on it, and then I'm going to finish up very quickly. This turns out to be the reason why we're inaccurate. We have 150 years of studying the effects of brain problems on behavior. In 1860, Broca pointed out that a problem here, a stroke in that case, causes aphasia, problems with language. And then from that point on, the floodgates opened. We have the reports of all these different kinds of weird and unusual conditions, from diseases that affect different parts of the brain. So we think, and I think we're probably correct, we think we're pretty good, far from perfect, but pretty good at identifying what part of the brain is affected to cause specific symptoms. The problem is these disorders, CBD, FTLD, AD, don't fully respect the parts of the brain that they're supposed to. So somebody's got to get them straight. So it turns out that Alzheimer's disease we think of as a parietal and a temporal lobe problem. But there are people, and I heard Dr. Grossman allude to this, there are people with so-called frontal variant Alzheimer's disease where the disease, for reasons that we don't understand, is more in the frontal lobe. They end up looking like patients with frontal lobar FTLD. The reason they do is because the disease is in the same place. So we go by what people, in a nutshell, what we do is we look at the symptoms and we know what part of the brain should be affected. And then we work back from that to saying, okay, this is probably, since it's this part of the brain, it's probably CBD or it's probably FTLD. But it turns out these diseases can be fooling us because they're affecting different parts of the brain. So I'm going to to me, it's a very interesting point. I'm not going to dwell on it too much because it gets a little esoteric. But I think it explains some of the variability in our diagnostic accuracy. Okay, diagnostic tests. How do you go about diagnosing this condition? Well, the same as with these other conditions. We do a good history and physical examination. Then we get imaging of the brain, MRI scan or CT scan, and we usually do these blood tests for so-called treatable causes of memory loss, dementia. Then we occasionally do a PET scan or SPECT scan. There's no real evidence, in my view, and people may differ on this, no real evidence that it's a terrific test. So I don't tend to get these on everybody, but they can be helpful in certain circumstances. The causes. Well, the neuropathologists, Drs. Trojanowski, Lee, their team, and neuropathologists elsewhere, are really hot on the trail of this tau protein. Having said that, I've about exhausted my knowledge of tau. So I know it's very important. Where's Dr. Chosinowski? He's going to kill me. He's in the back there. I'm going to leave that to him. He's one of the world's experts on this stuff. And I know this tau is bad stuff. It aggregates in clumps, and it affects neurons and does this kind of stuff. You get these neurons that are ballooned. They're too big. And these neurons are choking with this tau stuff. And tau is a protein that all of us have. It plays a role. But it's not playing the right role in these disorders. And as Dr. Grossman mentioned in somewhat more detail, tau is implicated in a variety of other conditions. You see abnormalities of tau in Alzheimer's disease and FTLD, and PSP, and a bunch of others we won't go into. Treatment. Well, unfortunately, we have no definitive treatment. We don't really understand the cause of the condition, and we don't have a definitive treatment. I'm going to defer to Dr. Trojanowski, who will be discussing in a half hour, 45 minutes or so, about emerging treatments, because there are some ideas that are being developed. But at this point, there is no drug that's approved by the FDA, and no drug that I think it's safe to say that any of us really think is effective in this condition. What we do now are we treat the symptoms. And, that's regrettable, but that's what we can do. Treatments for Parkinson's disease are not helpful. They usually cause more confusion. They're something that often gets tried, and it's not a bad idea to try it, because given the diagnostic uncertainty, it sometimes turns out that treatments for Parkinson's disease that we've called CBD, Parkinson's disease, CBD. And some people take the course of saying, let's try Sinemet, for example. Let's see if it gives any benefit. We'll try it cautiously with a quick hook if it looks like it's causing adverse effects. And it usually causes minor adverse effects, and we stop it quickly, because it's not really very helpful in this kind of condition. And I think that is it. Yes, it is. And it's 2 after, so I'm out of here.